whole things. This topic is how to prepare for regional anesthesia practical exam. So it's a certification exam. So you are going to become an expert in this area. It's a super specialized area. And there are different boards and different organizations like EDRA and IDRA and Indian Society of Anesthesia, and those sort of organizations, they conduct a very good course. But one of the most important course, that is the certification exam worldwide, which is revered, is the EDRA, the EDRA. That's the European Diploma of Regional Anesthesia. Whatever is the board, the different boards, the principle of the practical exam is all the same wherever you go, whichever country. So the key to success is, we have already tested all the candidates on the knowledge by MCQs and SBA. That is the part 1 of the examination. Some of the short answer questions also, some boards do it. So we have already done it, and you have quite a good amount of knowledge because you passed those written exam. The skills also, you have done a lot of courses and mock viva and practical demonstrations. Those goes on. You can do it in a lot of organizations, and I will come to it in a later slide. The other, the key to success, this is very important, is knowledge, skills, and attitude. The attitude is the we also see the life skills, like your problem solving abilities. So a person who has come with a fractured upper arm, and you trying to abduct the arm and trying to do an auxiliary block, it's not possible. So that is a problem solving abilities. You have to do some sort of a brachial plexus block without moving the arm because it's painful. Then the prioritizations are like, what things will you do first and which thing will you do next. Now, a classic example is local anesthetic toxicity. So whenever a local anesthetic toxicity thing comes, immediately everyone jumps into intralipid. So intralipid is quite on the 3rd on the list. So you have to do resuscitation first. I will come to it again in another slide. So never go into, I will give intralipid. That is not the treatment for last initially. So the last one is, you are using a cold jelly. Whenever you are doing practical exam, you will be told to touch the patient's skin to palpate some bony landmark, or you may have to use some cold gel. So always show dignity and respect. I mean, if it's a femoral nerve block, it's in the groin area. A lot of models are females, and I have seen candidates just come and suddenly take away the cloth from the groin area. So those sort of things are very, very bad, and don't ever do it. Just tell the patient very politely that I'm going to remove this, cover it, and it's a cold jelly coming. I will be putting a lot of pressure and all those things. Especially for our South Asian group of people, this is one of the training that we have to give, that when I tell you to go and do an ultrasound scan, just don't take the probe and immediately go there. Just do some 1 or 2 sentences to show respect to the patient. You have to read quite a lot, and I feel that journals are better than textbooks, because textbooks are mostly outdated. So textbooks for anatomy are very good, but rest of the regional anesthesia textbooks, they don't update every year, but the journals, they come up with every 3 months, they come up with newer ideas. So prerequisites, very, very important whichever board you apply, EDRA, IDRA, or any other courses. You have to go through different workshops. For EDRA, it has to be like 16 hours. So 10 hours of ultrasound workshop and 6 hours of a cadaver workshop in approved centers. So if you don't do it, then you won't be able to apply for exam. Yeah, the Indian Academy of Anesthesia, which conducts the IDRA exam and all those things, they have a very strict criteria that you have to do this many courses. You have to get it signed, and you have to do an official cadaver course. So go through the respective websites. Everything is written there. and you have to do those prerequisites before you apply for exam. The number of courses should be approved in their website. Most of the courses are approved. If you have a EDRA teacher teaching you or a qualified teacher teaching you, most of the courses are approved. The practical exam part is there are clinical questions. Now, why I put obstetrics as the first one is the clinical question comes not only on regional anesthesia, so only not nerve blocks. So obstetrics is now coming in a very big way. So don't remove obstetrics from your reading list. Then comes regional anesthesia in patients with comorbidities, and read all the region-based anatomies like shoulder. What will you do for a shoulder anesthesia, knee anesthesia? Laparotomy and thoracotomy are very common questions which are asked, but laparotomy also involves non-regional techniques, and I have put a slide in later stages, so you will see it. And also tell about the multimodal pain therapy. Don't jump into everything into nerve blocks. Multimodal pain therapy also works, and it should be told in all the regional exam. And first and foremost, always think that you are not a blocker, you are not a nerve blocker, you are not a technician, you are a clinician, you are a doctor. So you holistic medicine wise, you have to give paracetamol to most patients, you have to give some sort of a non-steroidals if it's indicated, and then you can do a regional anesthesia as part of the multimodal pain therapy. Then the second question, this is clinical question. The second question that comes is the problem-based thing. So problem-based is, I have put some problem-based questions in later slides. So local anesthetic toxicity comes very frequently. You have done a nerve block, the next day patient has a nerve damage. So those sort of problems are very common. Then you have to, these are the viva. The last two are the practical part, which is landmark-based blocks. So landmark-based blocks are very common in European exam. In Indian exam, it's not that rampant. So they may ask you just one sentence about which landmark you are palpating, but Indian exams are mostly ultrasound-based, but the European exam, there are equal marks for landmark-based and ultrasound demonstration. So you have to learn both of them if you go for European exam. But for Indian exam, it should be all right for only if you know the ultrasound anatomy of that respective region. We can't change. Yeah. We can't change the slide. So clinical scenario, you can raise your hand if you have questions in between. So I'm just going through one clinical problem. So this is one elderly patient with a lot of cardiac comorbidities, COPD on apixaban, and she has been posted for a fracture neck of femur fracture. So when you discuss about this patient as a doctor, you have to start first about the issues. So you have to say this is an urgent operation. So if you say emergency, that means you are taking the patient now. So these patients are urgent operation. In different countries, there are different guidelines. So usually it is taken as 24 to 48 hours from the fall. Then for the cardiac thing, you have to tell whether there is a murmur like aortic stenosis, and then you can order for echo. And orthogeriatrician is a very important part in some of the European countries. Orthogeriatrician means a medicine doctor who has an MRCP degree or a postgraduate degree in medicine. They are specially trained in elderly medicine, and they sort of optimize those elderly fracture neck of femur patients. So there are some posts called orthogeriatricians. So we try to talk to them and what to do about the medications optimization and prehabilitation, what we call. So these patients, any cardiac patient, whenever it comes to your clinical case, always remember that any cardiac patient, patient with atrial fibrillation, patient with left ventricular hypertrophy, any cardiac comorbidities in your pre-anesthetic checkup means these patients have a high risk of local anesthetic toxicity. So if you read the 2021 guideline of the Anesthesia journal, which is the Association AAGBI journal, it is clearly written that any cardiac problems means you should be very aware of the local anesthetic toxicity. So this is one of the issue whenever you have cardiac. Then comes the COPD. Always you think that spinal is better, and you should tell in the exam that I feel spinal is better. But again, rule out the contraindication with the apixaban and the aortic stenosis. So if there is an apixaban, read the ASTRA guideline, joint ASTRA and ASTRA guideline. Then you have to tell in the same breath what is the renal function or creatinine clearance. So an apixaban in an elderly person who has a kidney clearance problem, they will have a little bit more delayed clearance of apixaban, rivaroxaban, whatever the XA inhibitors are there. So that creates an environment that you are not a technician who is here to do a block. You are a 360-degree clinician with an expertise in regional anesthesia. Now the next question comes, so when you covered those issues, keep on talking and don't stop, because the moment you stop, they will go into some other questions which you may not feel comfortable. So I always suggest the examinees that keep on talking, that you got the scenario, what will you do? These are my issues and my anesthetic options are. Now, if you say there is an aortic stenosis, it is a contraindication for spinal, but you can do a low dose spinal like 1 mil of 0.5% heavy Marcaine. That should be more than enough. So you can do a CSC with a 1 mil, and then if patient has any pain, you can use the epidural to top it out. We use quite a lot of spinal catheter. Again, we just thread the catheter 3 centimeters inside the CSF, and you can give 1 mil and then build up the block. 1 mil to 1.2 mils is more than enough for a fractured neck of femur. Then comes these are the neuraxial technique. So always classify or you die. So classify means you are telling what technique anesthesia will you give. So I will always go for neuraxial and regional combined. So neuraxial, you can do CAC or a spinal catheter. Regional anesthesia, you